So this we'll take this for as a feed for our next speaker and presentation. And I'm very happy to introduce my colleague, actually, who is a real expert in ECMO and advanced cardiac support, Professor Dauwe from Leuven Institution in Belgium. And I'm very looking forward to his talk about modern approach to temporary MCS and VA ECMO. Please, Dieter, the floor is yours.
So good evening, everybody, and thanks for the introduction, Christophe. I'm actually going to talk mainly about weaning from temporary mechanical circulatory support as, of course, assessing recovery or assessing the lack of recovery is, of course, of crucial importance in the transition towards durable assists. And for the sake of time, I will mainly focus on weaning from VA ECMO, but there are, however, a lot of similarities between weaning a patient from VA ECMO in comparison to weaning a patient from another temporary MCS device like Impella. And as we all know, temporary mechanical support is only a bridging strategy towards a more definitive solution. So at best, bridging towards recovery, otherwise bridging towards a durable device or a cardiac transplantation. And sometimes if we think about a bridging strategy, this is the kind of bridge we have in our minds, like a solid bridge towards a better destination. However, quite often, if you practice clinical patient care for patients supported by temporary mechanical circulatory support, the bridge is sometimes looking a bit more like this bridge, so prone to potential complications like major bleeding or ischemic thromboembolic complications and leg ischemia. So complications are quite frequent during support with tMCS devices. So this actually means that every day that we round on a patient supported by temporary mechanical circulatory support, we need to do a risk analysis. So is the risk of decannulation still balanced by the risk of continuing VA ECMO support? And if this is not the case, you should definitely think about decannulating your patients from temporary mechanical circulatory support. In this risk analysis, it is, of course, of crucial importance to have a look at the potential for recovery and the expected time course of cardiac recovery, depending, of course, on the etiology and natural history of the underlying disease. So, for example, if you support a patient for a lymphocytic myocarditis, this is a completely different scenario than if you support a patient with pre-existing heart failure going into cardiogenic shock. So these are crucial things that you need to take into account. If we're going to talk about weaning a patient from VA ECMO, it's always good to have more or less an idea about the average support time reported in the literature of a patient supported by VA ECMO. And the ELSO registry is the largest ECMO registry available. And if you take a look there, you can see that the average support time with VA ECMO is around 6 days. This is a little bit longer if patients are supported for myocarditis because we aim towards recovery. So use a bit of a longer VA ECMO support time, and this is shorter in ECPR patients because there sometimes the neurological injury makes continuation of the VA ECMO run sometimes futile. So we're going to talk about weaning a patient from VA ECMO, and then understanding the underlying physiology of the ECMO and the patient interactions is actually of crucial importance. So I always like to start with this schematic, which is, of course, known by everybody. But in VA ECMO, you drain, of course, blood from the central venous compartment, and you re-inject the blood at the arterial site, which actually means that you give direct hemodynamic support to the patients. As you can see, the ECMO circuit in a VA ECMO configuration is in parallel with the heart and the pulmonary circulation. So a patient on VA ECMO is on partial bypass, and partial bypass means actually that you also unload the right heart and the pulmonary circulation, because you steal part of the preload that would normally go to the right heart into your ECMO circuits. Important to understand is that patients supported by VA ECMO have a dual circulation. So the total systemic flow is actually the sum of the extracorporeal blood flow in combination with residual native cardiac output if there is any residual contractility on top of your ECMO support.